more than 1 out of 10 babies is actually born preterm, which means before 37 weeks. And the March of Dimes gives us a D+ for maternal health around this issue. And as you can see from the slide, there's quite a bit of difference among the states in the United States, but when I say 10%, it's across the board. Black moms, non-Hispanic Black moms, have the highest rates, about 50% higher than everyone else. But I'm going to tell you the punchline of my talk right now. Look at those numbers, and what if we could get those numbers for everyone, including Black moms, down to 6%? We think we can with omega-3 fatty acids. So there is strong evidence in a scientific audience. If you start out and say there's a Cochrane review that says there's strong evidence that omega-3 fatty acids reduce preterm birth, less than 37 weeks again, or early preterm birth, less than 34 weeks, which are the most consequential, costly, stressful for families, births. You can reduce them by at least 42%. Keeping in mind, there's about 5,000 women in this review. Now, after this was published in 2018, we published a clinical trial that was funded by the NIH. It was a multi-site trial with 1,100 women, and a group in Australia published the ORIP trial, which had about 5,400 women. And both trials were not a success in the conventional way, because what we found in both trials was that only the women who started with low DHA status had a reduction in early preterm birth and preterm birth. Why might that be? We think it's because in Australia and the US around 2008, prenatals with DHA started to come into the market, and half the women in our trial were taking DHA on the day that we enrolled them. So I'll show you, well, I'll get a little ahead of myself here. So DHA intake is very low among US pregnant women. It's found in few food sources. If you look there, you see the really good sources are seafood. We have a seafood intake problem in this country for everyone, but particularly you will note there that 0% of the 1,180 pregnant women in the NHANES survey consumed at least 8 ounces of seafood per week, which is even ACOG and the dietary guidelines for America recommend 8 to 12 ounces of seafood per week for women who are pregnant or considering becoming pregnant, or even in their pregnancy years. So the intake is actually closer to, in our trial, was 84 milligrams per day on average, but there are reports as low as 54. And I want to tell you this because it was important as we developed the guidelines that you know, because in these clinical trials we measure blood levels of DHA, so we know whether there's adherence, and we know what the women's DHA status is. But what I'm going to show you in a few minutes is that it makes a difference what your status is when you start. On the other hand, if you think of every pregnancy, we have approximately 4 million every year in the US alone. There's just not the capacity to measure the blood level of DHA in every pregnant woman to give her advice. So we validated a 7-question food frequency questionnaire, and I will show you as my last slide. You can use the barcode and check your own DHA intake. But with 7 questions, 3 of which have to do with fish of different amounts of omega-3 fatty acid, fish categories in them, and then including egg yolk and chicken, which are kind of low. We did this test in 1,305 women that were enrolled in our trials in Kansas City. And we found that a baseline intake of 150 milligrams per day was kind of the cutoff for women who had the poorest DHA status. So just a couple of slides I'm going to show you from our clinical trial. And if you sort of orient to your left, women who had low baseline DHA status when they enrolled in the trial, which was a red blood cell DHA phospholipid level lower than 6%, had a conventionally significant reduction in preterm birth. And that happened whether they had low baseline status or on the other side of the screen, high baseline DHA status. They both had about a 27% reduction. And these are intention to treat data, I want to emphasize. We published an adherence later. We get even better results if we look at whether they actually took it. But this was so for less than 37 weeks. If you look on the left side, you will see that the preterm birth rate less than 34 weeks was reduced by half among low baseline DHA status, but no further benefit on the high baseline DHA status because they already had an extremely low rate of early preterm birth. And this is the same kind of orientation, only instead of talking about status, we're talking about their baseline DHA intake, the way it's not based on any kind of a clinical practice guideline. And I was asked to write an article promoting this idea, and I said, this is not the way we should go. We need to make this more of a consensus kind of process. And contacted Bert Koletzko, who I'd worked with before on other projects. He has begun the Charitable Child Health Foundation in Munich some years ago. And he invited Irene Satan from Milan, and the three of us put together this panel that developed the guidelines, and I'm going to go through the process a little bit for you. The scientific manager was Dr. Franziska Feldy. So that guideline was published earlier this year in AJOG MFM, the American Journal of Obstetrics and Gynecology, and it's entitled Omega-3 Fatty Acid Supply in Pregnancy for Risk Reduction of Preterm and Early Preterm Birth. You can see that there are already 7 organizations that have signed on to this. They've made it the standard in Europe, in their OB organization there. And there were 24 authors from 15 countries and all continents. There are a couple of the authors with us that are in this room today. I would just call out Bill Harris and Gretchen Van Eys. So the method is that we developed this steering committee and drafted, Gretchen and I actually drafted the initial manuscript, which really went through the evidence. What is the evidence that we should have a guideline around this? That was a rather extensive document. We went through a various editing process with Dr. Satan, Dr. Koletzko, and myself, and when we had a document that we all were happy with, we shared it with the other members of the guidelines committee. They had a time to review, comment. Then we had a consensus meeting in May of last year, discussed, revised. There was a lot of discussion. There were some points in the guidelines that people weren't sure about. Several of the obstetricians didn't really know about omega-3 fatty acids. We had to convince them on the evidence. We had to talk through the evidence. And then in the end, after a couple of meetings, we had anonymous voting on 10 proposed conclusions. A third conclusion was added later by a family group, a group that advocates for family, and we voted on that one as well. I think there was 100% consensus on that. So we defined strong consensus as greater than 95% of the 24. Consensus is 75 to 95, and you see we didn't have anything that was below that. So these are the conclusions. Intakes, and we started with safety because, believe me, the obstetricians, their biggest concern was safety. Intakes of up to 1,000 milligrams per day of DHA and EPA, or up to 1,000 milligrams per day of DHA alone, do not raise safety concerns. And we had a consensus of close to 90% on that point. I could say more about that, but observational studies and randomized controlled trials in pregnant women should show lower intakes of fish and lower blood levels of the omega-3 fatty acid, DHA, and EPA found in fish are associated with a significantly increased risk of preterm and early preterm birth. Again, we had consensus. And women of childbearing age should aim to obtain a regular supply of omega-3 fatty acids from foods, providing these fatty acids, including fish and oily fish, and or from supplements providing DHA and EPA or DHA alone. And we have strong consensus on that. For the general population, including women in their childbearing years, a regular intake of at least 250 milligrams per day, DHA plus EPA, as recommended by the European Food Safety Authority, is desirable. We had strong consensus on that point. For pregnant women, an additional intake of at least 100 to 200 milligrams DHA per day, as recommended by the EFSA, is desirable. Again, everyone agreed to that point. All 24 people to agree on all of these was not, I think it's an accomplishment in itself. Pregnant women with low DHA intake and or low DHA blood levels are at increased risk of preterm and early preterm birth and should receive a regular supply of about 600 to 1,000 milligrams per day of DHA plus EPA or DHA alone, based on results of randomized controlled trials demonstrating significant reduction in preterm and early preterm birth. We had consensus again. This additional supply should preferably begin in the second trimester of pregnancy and not later than 20 weeks gestation. High-dose supplementation with the goal of risk reduction of preterm birth should continue as long as there is a risk of preterm birth, that is until about 37 weeks of gestation, or until childbirth if before 37 weeks. This was actually a point of contention because those of us who don't think there's any risk to DHA were going, why can't we just say, take it? I don't think any OB is going to tell a woman to stop taking it at 37 weeks. And there's probably a lot of advantages for her to continue taking it because if she breastfeeds, her milk will have more DHA, and we know that's a good thing. But again, this is where the OBs and the nutritionists kind of diverged a little bit. Identification of women at increased risk of preterm and early preterm birth due to low DHA intake and or low DHA blood levels is achievable by screening with a few questions on dietary intake of foods rich in DHA and EPA. This was actually a surprise to me because I thought they would push back more on that than on the blood level, but they on the blood level, they said this is another way we can do it, but we need more standardization of methods. And that is indeed true because there are different ways people can measure DHA in blood, with red blood cells, with plasma, with phospholipids. So there is no standard for this at the moment. And it is important, this was the last one that was added after, was suggested after the process. It is important to provide women of childbearing age, pregnant women, and their partners with evidence-based information, preferably both verbally and in writing, on how to achieve an appropriate intake of DHA or DHA plus EPA for women of childbearing age and pregnant women. So after we completed this, we published something else later this summer because the secondary analysis of our ADORE trial was to look at race. If you're doing a trial in, our hypothesis was the DHA would reduce preterm and early preterm birth, but we didn't know if it would work the same for everyone. So we published this later. I can get it. Oh, before I go there, forgot I put this one in. I just wanted to put this up because this is a table right out of the guidelines paper, and if you look at that, all the the obstetricians actually requested we put this table in. They wanted to know what foods have DHA that we can tell our patients. And you can see there's very high categories of DHA, EPA. There's sort of a middle one, and then there's getting down into the lower categories. And they're all fish. They're all seafood, except when you get over to the lower categories, you can see eggs and chicken and maybe liver, which not everybody eats. So after we published the guidelines, we published this paper this summer in AJOG MFM. It was a letter. And I want to show you this because, and take you through it kind of slowly. The red lines for the preterm birth and early preterm birth that you see are the national averages for preterm and early preterm birth. But one of the things that you can see clearly here is that women with low baseline DHA status, whether they were Black or other races, have the highest rates of preterm birth, and they have the highest rates of early preterm birth. And when they got the high DHA dose, that helped a little bit in most of these cases. But if they started with high baseline DHA status and they got the high DHA dose, they had the lowest rates. And particularly, I want to point your attention to the green line in the Black moms on preterm birth, on the extreme left, because that number, 6.4%, is not different from the 5.8% we saw in other races. So in Black women, it actually brought them, if they started with high status and they got the high dose, they are not different in terms of preterm birth from women from other races. And this is a huge thing. It doesn't explain all preterm birth in the Black population and the disparity that we have, but it goes a long way to saying that we can do a lot better with moms. And what you see over there on the early preterm birth side, the Black moms still had about a 2% rate of early preterm birth, but they went down from 8%. 8% of the moms in our studies who were Black, who started with low baseline DHA and got the low dose, remember, not a placebo, had an 8% rate of birth before 34 weeks. So this is just the graphic that we have for the paper, and it speaks to what I just told you, how much moms should have when they're in childbearing years, how much they should get if they're not getting that in their childbearing years, either a little bit extra or a lot more if they're getting it in their childbearing years. And the only thing I would say here now is, since we published these guidelines in February, I would say that Black women need to be getting the 250 milligrams for sure and getting the higher dose during their pregnancies. And this is one of the things we're working on right now. And I think that's it. I don't know if I have time to do the takeaways, but I think I've made my points. So I will just go right to this, and maybe you can take a picture and check your own DHA intake. And I will take questions if you have.
Thank you, Dr. Carlson. I think as we've been going through these guidelines, I have seen your talk about stopping DHA at 37 weeks for pregnant moms. I didn't quite understand that, and I thought maybe that was because the baby would be so comfortable they never wanted to come out because of the DHA. But no. Is there a reason why you stop at 37 weeks?
No, it was because the guidelines say to reduce risk of preterm birth, and there was one group, mostly the obstetricians, that said, well, if you get to 37 weeks, you've reduced preterm birth, so why do we need to keep saying it, right? But we never said the doctor needs to tell them to stop taking it. We just said until at least 37 weeks. So I finally went along with that comment.
Joe Hibbelin here. As a follow-on to that, for the sake of the mother, there are meta-analyses that a gram a day of omega-3 fatty acids rich in EPA prevent and treat perinatal depression. So apart from the reduction of preterm birth, mothers will be less depressed and more attentive to their children if that guideline is followed through past 37 weeks.
Yes, we're not telling people to stop. I would not say that. I think it's important, as I said before, for human milk. There's somebody over here.
Hi, thank you. That's a great talk. So I wanted, my question really centers around kind of some other social determinants of health related to your guidelines. Yes. The guidelines assume, evidence-based information assumes access to care systems. that can give them that information, assumes, and getting more seafood assumes access to quality food systems. So there's intersections there, I think, specifically with some of the data you showed on race and the map you showed. There's increasingly in some of those states where there are higher rates of preterm birth, we're seeing increasing reproductive health care deserts. So I wonder if you can speak a little bit to some of those other social determinants and access in order to get the information and the quality food and things that these moms really need to reduce their preterm birth. If you could speak to that a bit. Thank you.
You make a fantastic point. When you make guidelines, the first step is to get some guidelines, right? These are new. When we disbanded the group, the first thing we did was have a conversation and say, doesn't stop here. There are steps that need to go beyond this in terms of access. And trust me, I live in a state or work in a state that's got a lot of rural where we've lost. It's a crisis in this country, but I know it firsthand from our own state that we are not getting care to pregnant women. Some women are driving 2 or 3 hours for prenatal care. We're having a lot of conversations in our own university. I think we all need to do our part, but it's also access to the foods, which I know the Seafood Nutrition Partnership has been working hard to help people understand what kind of seafood might be affordable, how to get it into the WIC program, how to get access. So the 24 people that were involved in this, we agreed, we'll keep working on this, we'll work wherever we can. I've been to ACOG the last 2 years and talked, and it's amazing the number of OBs in the room that come up afterward and say, I never heard of omega-3. There was a session on preterm birth at ACOG this year that mentioned a lot of things that can be used for various clinical problems, but omega-3s are the only generalizable effect that's ever been, the only generalizable strategy that's ever been shown to reduce preterm birth if you're not having something like preeclampsia or hypertension or whatever the other problems are that lead to preterm birth. But as you can see, I don't think DHA is going to reduce every preterm birth in this country, but it's reducing a lot of them. And it seems to be, I didn't get into this, but it seems to be around spontaneous preterm births, not the ones that can be prevented by aspirin.